Okay, good morning, good afternoon, and good evening, everyone. As we gather here today, joining from different parts of the world and different time zones, I would like to extend a warm welcome to each of you, and welcome to our webinar, "Are Suction Devices and Technological Advances the Future of Endourology? RIRS Leading the Way?" I'm Kasia Korab from Pusen Medical, and it's my pleasure to see so many esteemed professionals gathered here today. First and foremost, I'd like to extend a warm welcome to each of you joining us from around the globe. And well, we are here not only on Zoom, but also on a Chinese platform with approximately 300 people more listening to our webinar today. I would like to extend a special thanks to Professor Somani and our distinguished panel of speakers, so Dr. Steffi Wen, Dr. Esteban Emiliani, and Dr. Lorien Dragos. Thank you all for sharing your expertise here with us. Well, let's embrace this opportunity with open minds. And that's all from my side. I give now voice to Professor Somani, who will start the webinar for all of you. I wish you a very fruitful time full of knowledge and experience sharing.
Thank you very much, Kasia, for the warm welcome. Thank you to Team Pusen for allowing us to carry and conduct this webinar, which is very, very pertinent given all the advances in endourology and endotechnology. And we will talk about suction devices and technological advances, and if this is the future and how RIRS fits into that. I'm extremely pleased to have three close friends of mine who will be talking about different aspects. So Steffi will be talking about intraanal pressure and temperature, and is this the new frontier? And she is from Hong Kong. So welcome, Steffi. And then this will be followed by Esteban, who will be talking about suction cystoscopes in endourology and why I think he thinks and we think it's a game changer. So welcome, Esteban. And this will be followed by Lorien Dragos, who is going to talk about smaller scopes. Are these the future of endourology? And I should have mentioned Esteban is from Barcelona and Lorien is from Cambridge. And finally, I'm going to talk about the small suction ureteroscope and the suction access sheet. And really, is this something that is going to change clinical practice for all of us? And is it a combination of different things that all the speakers will talk about? So welcome to all the participants, both here on Zoom across the globe, as well as on our Chinese platform. For the Q&As, please feel free to type the Q&A. We will try and answer it as the webinar goes along, but equally, if there is a pertinent question or if there's something we want to discuss, we can discuss it at the end of the presentation. We might take a short question in between if time allows, otherwise we want to finish the presentations, answer your Q&As in the chat, and then take Q&As and discuss with the panelists towards them. So with that, I'm going to hand over the baton to Steffi. Welcome, Steffi, and over to you. Thank you so much.
Thank you, Professor Somani and Team Pusen for all this opportunity. Let me share my screen first. So it's on intrarenal pressure and temperature. It's the really hot thing of late. I have no disclosures. First, I'll let you see, I have to travel 42 kilometers every day to work. So I drive a long way along a lot of highways, and often I'm very worried about my tire pressures and tire temperatures because I'm worried that I might not get to work on time. So the only thing that's on my current dashboard is the temperature of my engine oil. So let's see how technology evolves. Going back to endourology, we do have a lot of first world problem. And it's because of some high power lasers that has come onto the market in the last few years, like TFL, as well as the high power holmium YAG lasers. And with the increased efficiency, with the increased hertz, there are different first world problems, such as pressure that's raised, heat, as well as visualization. Looking into intrarenal pressure, because of the high power laser, it delivers greater energy, but not all energy can target the stone, and some are absorbed by the water and increase the intrarenal pressure. So recently, there are a lot of publications talking about these concepts of laser efficiency, depending how you see it. And there are publications, an in vitro study looking into if you fire the laser at 20 hertz, only 52% reaches the stone, and the rest are dispersed into and absorbed into the water or other irrigants. If you're firing up to 50 hertz, only 23%. And if you use even high frequency, up to 80 hertz, only 4% reach the stone. And as you can see, there are a lot of energy lost to temperature. Thermal damages is dependent on two factors. One, of course, the level of temperature, and second is the duration of the elevated temperature. That's the thermal dose. And this relationship is not linear. I'm sure a lot of us will know that 43 degrees Celsius, it causes denature of the protein, and up to 56 degrees, the coagulative tissue necrosis occurs in pig kidneys. So it only takes 15 seconds to produce some permanent damage. A lot of studies are carried out, and the graphs, the bar charts on top shows from the left, calyxio, in the middle, renal pelvis, and on the right, ureteric temperatures, fluid temperatures measured at different irrigation from 0, 5, 15 to 40 milliliters per minute. And you can see the increasing temperature as the irrigation goes. So with the increasing watts use, there's also increasing temperature. But if you increase the irrigation, the temperature goes down. Same occurs for the graph down there. With a high irrigation green line, you can see there's a lower temperature. Also, with the activation of lasers, if you look at the yellow curve, with accumulative, if you step on the laser pedal not continuously, you can see the accumulative intrarenal pressure. But if you remember to take your feet off the pedal and stop lasering for some time, then you will see the temperature comes down with irrigation. But there are a lot of limitations for the temperature studies, such as they're mostly animal studies, and some of them just look into the temperature of the water or fluid, and it's not urine. As you know, different fluids have different absorbent coefficient, and these experiments usually do not have lithotripsy factor in it. So it's not really simulating the real clinical scenario. Also, if it's a laboratory study, there's no heat sink effect from the renal perfusion. So these are only temperature studies performed in a limited setting. But reviewing all the literature, you can see there's some advised temperature settings with advised power level, as well as correlation with the irrigation flow. And often we may not use a standardized irrigation inflow. Many units may use just irrigation by pressure with a saline bag hanging. So to summarize, with temperature, you have to look at the inflow, outflow, laser energy, and the positioning to avoid any thermal injury. With cool irrigation, you can lower the temperature, and continuous flow can also ease off the temperature. For outflow, we have the conventional ureteric access sheath, but we also have the suction ureteric access sheath that my esteemed panel will talk about later on. And for laser energy, we have to know how to use it wisely with the correct power and good practices. Moving on to lower intrarenal pressure, why is it so hyped up and important? There are a lot of pathological and clinical studies looking into intrarenal pressure that a normal level is probably below 20 or 30 millimeters mercury. That's a safe level. But above that, you will start to see pyelovenous backflow. And this is the origin of all sepsis. Looking at the systemic reviews, Up to 5% have sepsis after uteroscopies. Independent risk factors are as follows, but only the ones highlighted in red are modifiable, with irrigation pressure that's modifiable and also surgical time. And these could be solved maybe with suction, either with through a flexible and navigable uterine access sheath or through some processors that I will show you later on. And also, there are also means to have a real-time feedback of the intrarenal pressure by sensors with various platforms that I will show later on. So to summarize, safe intrarenal pressure settings, you look at the inflow that is as low as possible without collapsing the whole system. So the advised level would be gravity, like 60 cm above the patient, or less than 100 millimeters mercury continuous pressure. And note that with instrumentation in the working channel, there's always lower intrarenal pressure. There are some smart pressure regulating irrigation systems. With hand pump irrigation, there's spikes of intrarenal pressure that we should be cautious about. For outflow, the as big as maximum as that would allow the system to not totally collapse. Of course, access sheath is a norm that we use now, and it's well recognized that it can lower the intrarenal pressure. With the occupying of the working channel with basketing is also lowering intrarenal pressure. And of course, the new fans. So to summarize, with these pressure, heat, and visualization problem, we can control the power. Note that we can occupy the working channel. Remember some pauses between laser activation. You should note the irrigation flow, the flow rate, as well as consider using chilled fluids. Suction either with in-scope, direct in-scope suction, or through access sheaths. And we'll focus on some of the new innovations. For intrarenal pressure, currently there's no commercially available system to measure intrarenal pressure, the intrarenal temperature, but we do have a company upcoming. On the right lower corner, you can see a fiber that can measure the temperature as well as the pressure at the same time. And I was told that in a few months' time, they probably come up with a prototype with a 7.5 French scope uteroscopy that could measure two at the same time. So I'm really excited about this. For intrarenal pressure, the FDA approved the one of the flexible uteroscopies last year. And the studies back a few years ago are mainly focused on invasive methods using manometry via the percutaneous nephrostomy. But non-invasive methods through endoscopic means could be uterine access catheter, pressure sensor wires, but these are off-label use, uterine access sheaths that integrates suction, irrigation, as well as IR measurement. There are other processors and flexible uteroscopies that are shown. So this is one of the systems that uses the access sheath, and the processor on the right side will have the intrarenal pressure measured. You can see on the blue there's a few small holes right at the junction of the rigid part and the soft part of the flexible uterine access sheath that's noted on the purple arrow. That's where they detect the backflow and it will be sensed by the processor. And that's where they generate the intrarenal pressure. It is a smart system because when the intrarenal pressure exceeds the set limit, it will stop the irrigation. So another system integrates suction, irrigation, and intrarenal pressure monitoring as well. On the right side, you see a non-pulsatile irrigation flow. In the middle, you can see a real-time intrarenal pressure monitoring. And you can see, so this is one pressure intrarenal pressure monitoring. For the left side, they also have an irrigation pressure monitoring. And the left lower corner, they have a suction monitoring as well. So it's a three-way gated system. So this is an even more complex system than the last one. So there's a lot of technology advancement. On the left side, there's an off-label use of the pressure sensor guide wires. And on the right side, you can see we use flexible uteroscopies to measure the intrarenal pressures. So it's just like a normal uteroscopies, but for the pressure sensor wires, you need two screens, one showing the uteroscopy image and the other shows the pressure sensor wire. And for the right side, half the screen shows the normal uteroscopy monitoring and the other half shows the pressure monitoring. There are other different platforms that I will not go further in, but the main difference is I draw your attention to the different size of the scopes that's available commercially. And the last line here, they have different engineering concepts. The one scope calibrates to water and the other calibrates to air. So on the left side, you can see the Elite in action is a bigger scope, and the right side is another Zebra scope that's in action that we measure the intrarenal pressure. So with the fans, suction devices can lower the intrarenal pressure as well as the temperature. So with the time constraints, I'll just show you a small glimpse of how the one of the scope of intrarenal pressure measure monitoring works. This is how we withdraw the scope, and you can see there's an intrarenal pressure of around 20 to 30 millimeters mercury. For our surgery, we've noted that the maximum intrarenal pressure, if under suction, does not exceed 30 millimeters mercury for more than just 277 seconds. So it's actually a very safe procedure. To summarize all the non-invasive ways to monitor intrarenal pressure, you can see the conventional methods using the ureteric catheters or pressure sensor wires do not have suction in them and do not have an alarm system. But the new ones coming up with the ureter access sheaths, or even the newer pressures smart processors, or the flexible uteroscopies that can have inbuilt pressure sensors, they have the suction that's available. So it's a combination of efficiency, safety, the quality of life of patient, as well as the surgeons that we have to look into. So if you remember how technology has come along, the current technology in cars, they even have tie pressure sensors and tie temperatures that we can monitor nowadays. So even cars are so advanced. I think endourology is also very exciting. A new era has arrived, and we have recognized the importance of intrarenal pressure and intrarenal temperature, and the ability to measure them real time and in commercially available products. Maybe an ideal system will come soon that integrates pressure monitoring, temperature monitoring, irrigation, as well as suction. The true endourologist focuses on the kidney and not just the stones, so we do need to take care of the pressure and temperature, intrarenal pressure. I have to thank the whole team and Professor Somani for all the invitation and the support, and my team back in Hong Kong. We do have a workshop focusing on the new era of endourology. Please feel free to join. And that's the end of my presentation. Thank you so much.
Thank you, Steffi. If it was a presentation in a live meeting, there would be lots of claps, I'm sure, and lots of cheering. That was wonderful. You have really shown us the conceptual future of how things are progressing and how we will be able to measure it. For those participants who are with us, please feel free to ask Steffi and all of us in the Q&A so we can answer them. And hopefully Steffi will catch up towards the end once we have listened to all the presenters. But thank you so much for this wonderful presentation. With that, Esteban, I will hand over to you for your talk. Thank you.
Well, thank you so much for the invitation. Here, it's share my screen. Thank you so much, Pusen, for the invitation, and Professor Somani for having me in here with you. and I'm going to talk about suction cystoscopes and why the suction in this new scopes that we are having in our armamentarium can be a game changer, as just mentioned. So why do we need single-use cystoscopes? There is a thing that we have to take into consideration is that we do millions of cystoscopes every year, of cystoscopies every year in every center, in every country, millions. So it's for now that we have this technology, it's for each center to see if this is cost effective and effective for their centers, especially because we have risk of cross contamination, which is the main, let's say, advantage of this. One of the main advantages of using these materials. You know that we have sterilization and the reprocessing of those cystoscopes, of the millions of cystoscopies done every year, needs specific training, specific personnel, specific equipment, and we need specific sterilization process. At least we should use high disinfection, as mentioned in some articles, but now even some ureteroscopes and some companies have banned the high disinfection from their process. And if we don't do it well, we will have minimal bacterial destruction in this cystoscopes, especially in the working channel that need to be well perfused and well sterilized. There is some studies that we've done with ureteroscopes, and we know that pre-ureteroscopy, this group from Amsterdam showed that 12% of the ureteroscopes had positive cultures. So I think we have to mention this and just to show how the sterilization process can be difficult to, sometimes can be difficult and it can come with some problems. Now, what is the present and future of endoscopy now that we have this single-use scopes and that we know that it's they're worth using? Well, then we have integrated aspiration with these valves that will help us aspirate fragments, reducing perineal pressures, as you will see in the trends, as you will see the trend of the study that we have nowadays. I want to show you a case that I recently saw and on how you can, in a simple cystoscopy, you can use these kind of materials. See that a patient comes with hematuria. You see this stone blocked in the urethra. You can push it down, and you can see how you can even start thinking of treating these patients. Once you have hematuria, doing a good cystoscopy can be a little bit difficult. And if you have aspiration, you will see that it's going to, this patients can have some bleedings after this kind of maneuvers. This aspiration can improve your visualization, and then once you are treating the zone, for example, in the bladder, you can completely aspirate the fragments that are being done and leave the patient completely stone-free. And this is in the bladder. The other good, let's say, indication of this aspiration single-use cystoscope is with flexible nephroscopy. It's important to mention that this the cystoscope is only 15 French. 15 French is very important because we can use it in any kind of mini PCNA. And the other thing that is very important, sorry about this, is that the working channel is 7.2 French. 7.2 French is a big working channel, and we know that for a good aspiration, we need big working channels to make it feasible. If you see the equation of the flow rate, you will see that it's proportional to the cross-sectional of the area of the tube. So the bigger the tube, the more flow rate you will have, and you will have better aspiration. So this big working channel is great. So you can use it in flexible nephroscopy. Sometimes it's very difficult to reach in a single puncture the stone. I always use flexible nephroscopy after my PCNS or at the end, because I want to increase my stone-free rate at maximum, and I want to check all the calyces without without any radiation exposure, extra radiation exposure. And I want to use the single-use scopes because I decrease the risk of scope damage. This is one of my cystoscope that I screwed up when I was doing this nephroscopy. And you can just check how you can check the kidney with this incredible digital view of, that we have with this new single-use scopes. The other good thing is that the scope is, as I mentioned, 15 French, so you can use any axis less of 18 French, which do a great mini PCNN. We do routinely 18 French because we have to feed some old cystoscopes through those, which are a little bit bigger. But with 15 French, you can use 18 or even 17.5, 17 French mini access to decrease the bleeding of your treatments. And now we have new technologies for homeo. We know all of us how thulium fiber works. You can see the microdosing that we generate, especially in mini PCNN. You can see the fragments, the quality of the dust that is great. And even if we do this with mini PCNN by treating the zone with laser, as we do with thulium, you can see the dust quality. We want all of this to be out of the sheet. That sometimes it's quite difficult depending on the site of the kidney where you use it. So suction is really important in this flexible nephroscopy. So there's if you see the latest reports, there's a trend in aspiration in PCNNs. There's a trend towards reduction of overall infection rates with aspiration. So this is important to have into consideration. And stone-free rates are comparable, and we may say that there's a trend also to have shorter operative times. Besides stones treatment per se, this is really important for some cases, as this super stones or mucus patients, where you cannot treat this with a laser. It's impossible to treat. You have to retrieve it. So aspiration in these cases to reduce intrarenal pressures, because we know that this patient is infected, and you can remove all of this. It's very, very interesting, especially for these kinds of patients with this mucus or subite stones. The other thing is that when we use this kind of elements, we have always low intrarenal pressure, and as you saw in the last presentation, this is very important to reduce septic complications. You can see that the kidney is quite a little bit collapsed, and this is very important to maintain the patient in a safety zone. It's also very useful for some kinds of surgeries. For example, this patient that had obstructed upper callus, you can see what we removed from the patient. So having aspiration is very useful, and it's also useful for specific patients, as patients with renal bladders or ileal conduits, because there's always, when you do endourology in these patients, there's always surprises. You always have to check the renal bladders or the ileal conduits, and sometimes it can be difficult to remove all the mucus and all the debris that this patient have to really treat the stone. So aspiration in this patient that has mainly subite stones is really important. And to finalize, there has been some systematic reviews. This is from Professor Somani also, to see that there is a trend for a lower environmental impact by using single-use cystoscopes. We also did this review published last year, and we saw that using single-use cystoscopes, we had that overall the reprocessing and sterilization process of reusable cystoscopes was found to have a significantly higher environmental footprint compared to all the process, comparing all the process between two of them. So that was it. I just wanted to give you a clinical hint on how this single-use scopes could be very useful, especially by having aspiration during the procedures. Thank you so much.
Thank you very much, Esteban. It almost feels like it is not just a way forward, but actually suction, as you've shown, can really have a big advantage when you're doing some difficult procedures using a flexible cystoscope. And actually, we have found the same, that you may not need it for every case, but there will be definitely cases where the suction, especially when the access is difficult, the suction really helps you to do the case in a much, much more better way without struggling. So definitely there is a future for it. And with that, the next speaker is Lorian, who is going to share his wisdom about smaller scopes and smaller ureteroscopes. And are these the future of endourology? Thanks, Lorian.
Thank you very much, Pascal, for your kind invitation, and many thanks to the Pusen team for arranging this interesting webinar. I've got a few minutes to let you know about what I think about the future of flexible ureteroscopes, and do we actually need to have them smaller. To start with, as an endoluminal, from the endoluminal endourologist's perspective, it's very important to remember what we are dealing with. And this is obviously the ureter, which may be our best friend, but also can turn into our worst enemy. It's very important to respect ureter and to understand exactly what we are doing and what we are dealing with. We have to know, and all of us know very well, the anatomy of the ureter. It's a 3D anatomy, so don't consider it just as a simple tube. And it has obviously curves and natural constrictions, areas where the ureter is tighter. Just to remind you, the pelviureteric junction, the crossing with the iliac vessels, and the ureterovesical junction. What about the ureteric size? Different studies over the years were done on cadavers and most recently on modern imaging investigations. And I just need to remind you that 3 millimeters should be considered the upper limit of normal ureters. Obviously, this changes when there is obstruction. The ureter may get more dilated, but when we treat kidney stones and in a virgin ureter, this is what we have to respect. What does this translate into when we consider this 3 millimeter diameter and adapt it to the tools that we use? It's basically more or less 9 French. Not too much, is it? And remember, we have to respect and adapt the tools to the ureter and not force the ureter and try to adapt the ureter to the devices that we use. If we do that, if we don't respect the ureter, we end up with ureteric injuries, and this is probably Professor Straxer's most famous picture. All of us have seen it thousands of times. It's still very relevant, it's still very important, it's still an image that we have to keep in our minds when we operate. We are using access sheets, and we know since at least 2003 that probably the most important advantage of an access sheet is that it keeps the intrarenal pelvic intrarenal pressure low and hopefully prevents sepsis. But when we use an access sheet, the first obstacle is the ureteric orifice, and sometimes this may be a problem. And it would obviously, just looking at these images, be very, very important to have smaller size tools. Access sheet is the usage of the access sheet is quite controversial, and whenever we use it, we have to very carefully balance risks and benefits. I'm not going to go into details on this topic, but remember that we use force to insert the access sheet. Probably one of the most difficult things to teach our residents, our trainees, is how much force do we use? What is safe? And that comes with experience. Obviously, the first rule of endourology, I would say, is do not force. Respect. I will say this many times during my lecture today, respect the ureter. And it has been proven that the larger the access sheet, normally the more force that we need to insert the access sheet through the ureter. We know from this study that forces from around 4.8 newtons may already result in ureteric injuries, and forces more than 1.8 newtons may consistently result in substantial injuries. We also know from this very nice and recent randomized controlled trial that ureteric injury increases, the risk of ureteric injury increases with the size of the access sheet. And this is again the image from the ureteric injury classification. This has been done with 12-14 French access sheets. Despite that, what we've learned so far is that most of us worldwide, the 12-14 French access sheets are the most used access sheet. But the access sheet is not the only thing we have to consider. For sure, we need to understand. We will use the ureteroscope, and we need to understand the size of the ureteroscope compared to the size of the access sheet. You can definitely squeeze a 9.9 French forcefully through a 10 French ureteroscope to a 10 French access sheet, but that's going to come with no benefits whatsoever, and it may lead to severe problems in the end. My good friend Emre from Istanbul published this study quite a long time ago. I think it's almost 9 years now, comparing using different scopes and different access sheets, and they concluded that a reasonable compromise would be to use a scope that is no larger than 8.5 French with a sheet that is with a 10-12 access sheet that would hopefully result in less ureteric risk or decreased risk of ureteric injury. However, it would be much better if we could use a 7.5 French scope through a similar sheet or even through a smaller sheet. What do we have? What do we have so now? So the traditional scope manufacturers like Olympus, their digital scope is 8.5 French. The fiber optic scope, which is a bit thinner, is 7.95 French. Still relatively large scopes. But Wolf, a multitude of scopes, starting with the fiber optic one, BOA, which is 8.5, 8.7, the digital one, Viper, single channel, 8.8 French, Cobra, which is, we must admit, a two working channel scope, but it's also the largest one in this report. It's a 9.9 French scope with two working channels, 3.3 French each, and then the single-use scope developed and manufactured by Wolf is again a two working channel scope, pretty large, 9 French. One channel is the standard 3.6 French, and the other one is 1.65. What about Storz? Their digital scope Flex XC is 8.5 French. The single-use one, Flex XC1, is 9 French, while the thinnest one, the fiber optic Flex X2, is 7.5 French. And probably this is more or less what we should consider as the current golden standard in terms of scope size. You would say we can actually use the scope without a sheet. Why do we need an access sheet? What do we need to get? Because if even a 9 French scope or a 10 French scope is you can pass it through the ureter and treat the stone without an access sheet. again, this might have been true a couple of years ago, but now I don't think that's true anymore. And this is because of the advent of the new suction sheaths. And it has been already proven that they really improve the outcome of our procedures. And they allow us to tackle larger stones. So I think we are going to continue to use access sheaths because of this suction devices. So a very important parameter to evaluate with the access sheath endoscope is, as I previously mentioned, the ratio of endoscope to sheath diameter. And this very nice study published very recently in March this year shows that with a standard sheath, this ratio should be more or less around or less than 0.75, while with a suction sheath, to get a proper control of the intrarenal pressure, you still need a ratio of less than 0.85. So this is something quite important when we choose our ureteroscope and our access sheath. The same team published previously quite a nice study, again comparing standard access sheaths and suction sheaths, showing that at a ratio of 0.75, stone fragments measuring less than 0.25 millimeters are evacuated alongside the scope, while with a suction sheath, you will be able to evacuate a bit of a larger fragments. So definitely you will need, it's quite obvious that we need small access sheaths with even smaller scopes to be able to be very efficient. Now going to the single-use scopes. As you can see, there's plenty, as we all know, there's plenty of them, and most of them are following what I should say, the golden standard of 7.5 French size, more or less. But remember, this, you have to be careful and you have to check your scope's characteristics. 7.5 may be the tip, while the rest of the shaft may be larger, 8.6, and this is the part that goes through the access sheath, and this is the part that is important as well, not just the tip. So when you use a suction sheath, make sure that you know very well the size of your scope. This is not the problem or not the case with the scope developed by Pusen, which is a 7.5 French scope all the way, and it basically shows that the future is here. We already have these devices, we already have these instruments, and definitely we need scopes that are smaller, but also able to do all the procedures that we normally do with a flexible ureteroscope. I'm going to conclude here, and I think, as we know, an image is worth 1,000 words, but probably a video even more. And this is from a live, semi-live case I was preparing for a meeting, and it's me trying to put in a 11-13 French access sheath, and as you can see, failing. Obviously, I took the second wire out. I took and then I tried to put the inner part in a bit of the sheath and see if the ureter is large enough to accommodate the scope, and it wasn't. So I had to give up. I didn't have a smaller scope to use, and I had to send the patient and book for another procedure. That's me for today. I hope I kind of convinced you that we need smaller scopes, and many thanks again for listening to me and for inviting me to talk to this nice webinar.
Thank you very much, Laureate. So it seems like smaller scoops are the new better scoops by the sound of things. And certainly, logically, if you had a small scoop on the last case you presented, and if you tried it, maybe you would have been able to do the case without stenting. And I think that's the reality of it. You know, if you are that patient, whether you are a paying patient or whether you're in a system where the healthcare is paying for the patient, you would ideally want to avoid second and third procedure if possible. So with that, and thank you again, Lorraine, for this brilliant talk and analogy, a lot of details covered. I'm going to now share my screen and try and see if we can bring these two topics together, which is the smaller scope as well as to try and bring the suction both together. So I'm just going to share this. Hope you can see it. So, and the question really is it a combination of suction urethra scope and suction access sheath? So we know that smaller scopes are there, but what about scopes with suction? And what about suction access sheath? And what about doing it together? So I will have some videos, and in the interest of time, but also to make sure we use it, please feel free to put stuff on the Q&As. So far, we haven't received any question, but if there are, if you want to ask something, please do, so we can answer it either during or just after this talk. Otherwise, I'll have to ask our panelists some questions. So these are the relevant conflicts, and I want to acknowledge Vineet, who has given me some of the data. What is the future? There's lots of things that are future of stool surgery in all of these aspects. But I think the most important aspects of the future would be making the surgery safer. And how do we make the surgery safer? By having temperature and pressure monitoring. And the second aspect is to making them completely and totally stool-free and avoid recurrences. And how do we do that? By having suction measures. And perhaps the last aspect would be to not fail the procedure and do the procedure, like Lorraine said in his last case, if he had a smaller scope, he would have tried it. So maybe having smarter and smaller scopes. So pressure monitoring, temperature monitoring, suction, and smaller scopes, I think these constitute the bulk of what we are going to use in the future. So this has already been covered. Temperature is extremely important. If we don't know it, we will have these injuries, and that's what causes ureteric stenosis and parenchymal damage. And then pressure is also important. And in this study, it showed that above 81 millimeters of mercury, the rates of sepsis of 5% and 5 complications, all 5 had a higher intrarenal pressure as was measured. So again, it brings into the question of measurement of intrarenal pressure. Is suction the future? Maybe it is. And I think most panelists believe, and I think most endourologists believe, and you can use the suction sheath, you can use the suction scope. And why is it important? Because it helps with intrarenal pressure control, temperature control, because as you're sucking intermittently, you're not that worried about pressure and temperature. You have enhanced visualization because in Esteban's talk you saw if there's a bit of bleeding or oozing, you can suck it and it improves the vision. Perhaps, rightly or wrongly, you might push the procedural limits to doing bigger stools or more complex cases. Overall operating time is probably going to reduce because with suction, you are enhancing the procedure and you're so reduce risk of infection, ultimately with sucking out the fragments and dust, and that will translate into lower recurrence. So I think suction would probably help in all of these aspects of endourology in day-to-day practice. What is the advantage of small scopes? Lorraine has nicely covered it. You have better irrigation, slimmer sheets can be used, so avoiding sheath injuries. Smaller scopes would mean less pre-stenting, more primary ureteroscope, less post-op stenting, and the scopes are readily available. And of course, with smaller scopes, the other advantage is that when you're using it for the access sheet, there's a bigger return to water. So you've got a bigger channel through which the irrigation outflow will happen. So giving you better outflow, reducing the pressure and better vision. Now, are these the feature, these single-use scopes? I think you don't have to use in all cases, but you do use it in cases of larger renal stones or lower pole stones, abnormal anatomy, previous sepsis or multi-resistant organisms. And so that brings me to the suction ureteroscope. So this is the Pusen suction ureteroscope. You've got a adapter there with a port seal, which is permanently built in for laser. You've got the button mechanism for suction, which is quite handy. And you've got the deflection per usual. And the button mechanism also allows you to put that suction to the direction in which you want. So you can have it on the left, right, or wherever you want in terms of the direction. So the scope itself is similar. It's slightly more intuitive. It's a slightly more ergonomic design, as you can see, and the button allows you to aspirate it. So what are the main advantages? I think apart from the standard advantage of a single-use small scope, the suction system is a big advantage, and I'll say some clinical cases of these. And how does it work in practice? This is how it works in practice. So as you push the button, as you can see, you have suction that happens, and it's a single channel, so the inflow becomes the outflow. So you do have to use more irrigation for these cases, but it's easily maneuverable, and the suction causes a negative pressure to collect fluid and hopefully some dust. Now, this is a report of a 48-year-old female with 2.1 centimeter stone with recurrent UTIs, and we use the suction unitroscope, the 7.5, for 3 reasons: to keep the pressure low because history of recurrent UTIs, to slightly reduce operative time if possible, and to try and fragment some of these stones. And I'm going to run it. It's abbreviated. The whole case of 2.1 centimeter took about 32 minutes. Obviously, I shortened it. So the advantage here is, as you can see, as I'm lasering, I'm not having to stop and start because the vision is not obscured. The snow globe appearance or that dust covering your vision is not happening as much as you would expect, because you're intermittently sucking as the fluid is going in, you're aspirating. But because you are in control, you're not aspirating too much, or the system is not collapsing. If you had too much suction, the system would collapse. But because you've got a button which is helping you, you don't have to have too much suction, and you can just do intermittent suction and keep carrying on. And I think that is a big advantage for some of these cases in terms of saving intrarenal pressure, or perhaps getting better scope usage because you save time. And once you've broken it, again, I'm using the suction to kind of get rid of these fluff and the debris. Until the scope, currently it is 3.6, the same sort of channel size, but until the channel size improves, I'm not sure you can really suck out fragments. I think you need a bigger channel for that. But in terms of sucking out debris and carrying on with the procedure, I think this is very good. And you don't then have to worry about the temperature and pressure. So here you can see, the procedure is going very well. You're not having to really worry too much about other aspects. So this is for me, this is a big game changer in doing difficult stones. And then you can see it's a bit of dust. If you had a channel size which was slightly bigger, perhaps it would impact the scope size, but you would have been able to also aspirate these. And as you see, when I'm coming out, when I aspirate, you can see debris getting aspirated, but not enough for fragments, but enough for debris. As you can see now, you will be able to aspirate the debris as well. So I think this is probably going to be a real game changer because it's not just digital, it's small, but it's also got the suction advantage. So the next case is an iatrogenic history of mid-ureteric stenosis with a small stone in the lower pool. And again, we wanted to use suction because the kidney was quite hydronephrotic, and we wanted a small scope to overcome the structure. So I've got 3 small videos to show this. You can see the structure. It has only just about allowed the wire to go in. It's quite tight. And we try and do an endopallotomy to open the structure, hopefully to get the small scope in, which we did manage to. So again, the advantage of the small scope here is to try and not make a very big incision, let's say, for endopallotomy, and so that you're able to get in with a small scope. The next video, you can see you've got a lot of dust and debris. The kidney, as I said, was hydronephrotic, and rather than aspirating it, you can use the suction button and aspirate the debris and the mucus and whatever, the fluff through the suction channel. And again, that is also useful in these cases because when you're sucking, you can sometimes get the stone closer to you, which otherwise would have been difficult. So in the next one, you can see that the stone is there, but I am still going to do intermittent suction, not just for the dust, but also to get the stone closer to my laser fiber, which in a difficult case, when it's hydronephrotic and the stone is in a big distended lower pole, can be difficult. So by doing this, I'm also manipulating the stone to come closer to the laser fiber. So again, perhaps an advantage. And you can see with the suction, I'm able to now move a small stone fragment. We didn't take it out of this because of the stenosis, but you can see with suction, I'm moving the stone fragment. So it is possible to do that. So I think you probably can clear debris, as I've shown you, improving the quality. The vision is generally very good. And fragment retrieval through suction system. Dust retrieval, yes, fragment, you probably need a bigger channel for that. This is another case where we had a large stone, and in fact, we initially thought because of the encrusted stent, initially we thought maybe we will do a PCNL, but because of the suction access sheet and a small scope, we thought, okay, let's try through ureteroscopy. And you can see it's all soft debris and dust that we are fragmenting. And as opposed to doing a PCNL, they are able to do ureteroscopy and remove this fragment. So you can see all this dust. As you're coming out, and this is shown by other speakers as well, you come out and all these small dust and fluff gets sucked out. So you can actually remove a big quantity of these. And because the pressure is not very high, potentially the procedure can be slightly longer than what we would consider as our norm. So you can go for a bit longer because you're sucking out the bits. So again, this is something of a game changer for these complex and difficult cases, which historically would have needed a PCNL. Sorry, I'll go back. This is another case with a 71-year-old male and 2-centimeter lower pole stone, hard stone. You can see it measured. And again, we use the access sheet with suction. We use a TFL laser and the 7.5 single-use scope. And you'll see here how the suction sheet beautifully allows us to make it completely stone-free. So here we are trying to fragment it with a TFL laser. It is in the lower pole. The suction sheet can actually bend fully, and you can get the sheet to where the stone is in most cases. May not be in every case. Of course, you have to use it carefully, but in most cases, the sheet will allow you to bend, to get the stone and to get the best out of the sheet and the scope. And when you're coming out then, because the sheet is end on with the stones, you can really get out these fragments. So here you can see I'm trying to manipulate the sheet to where the stone is. And once you do that, there you can get these fragments out without no problem. So you can see now the fragments coming out. And these were hard stones, so they're not that soft. But by doing that, you can keep going in and out without using a basket in most cases, and you can get out. I do tend to use baskets in most of my cases, but not all cases. But in this case, you can see just by going in and out, you are then able to retrieve these stone fragments through suction, which I think is a huge game changer in the concept of suction. So small scope using a 10-12, so 7.5 French scope and 10-12 access sheet, which is not very big. Remember, and you can do the job brilliantly just by doing that and going in and out to try and get rid of. So you can see the last few fragments, I'm just taking it out. Now, normally what would you have done? You would have left the debris or the dust and a stent assuming that, well, these will pass through. And usually it doesn't, and they cause recurrences. But here, actively, you're sucking out these with a suction sheet. And I think this is incredible. So we did get a CT scan the next day. We don't normally, but we thought, well, does it really work? And we got a CT scan the next day. And on the CT scan, the patient was stone-free. And that really is the proof of the pudding, you know. So this is another case where a pediatric patient, a pediatric PCNL was planned, but the stent had retracted up. You can see the stent has gone retracted up. It's very tortuous ureter. So we had to get the stent anyway. And since we're going to get the stent, we thought, okay, should we try a ureteroscopy from below? It's a dilated ureter. Maybe we can use a suction sheet and do the stone this way. That's what we did. So use a suction sheet, and here we are using the small scope. And you can see the stone is disintegrating. It's a soft stone. But as opposed to doing a PCNL in this kid, we were able to do a flexible ureteroscopy and suction aspiration of all the fragments via the suction sheet. So again, this is something that we wouldn't have been able to do because the bulk of the stone is still quite big. So if you just fragmented and left it for it to pass naturally, you'd be a little bit worried. But with a suction sheet, you don't have to do that. You can actively suck out all these debris, etc. And in the end, you were left with fine dust, but the rest of it was all sucked out. And again, this probably will change the concept of even pediatric ureteroscopy. So you can use suction sheet safely, and provided you're using it safely, in the concept of pediatric ureteroscopy, you might be able to push the boundaries in doing larger stones. You might have to have a pre-stent for ureteroscopy, possibly, especially in younger kids, but then you avoid doing a PCNL in some of these patients. May not be completely avoidable, but in a lot of these patients, you might be able to do it from below. I think the experience of adult ureteroscopy definitely helps for these cases, because if you're used to using access sheet, and suction sheets, then actually it is helpful because you are not worried. If you're not used to, so here you can see it's really sucking out quite well all the dust and debris through the sheet. We could have probably, I didn't have a suction scoop that day, but probably some of them would also have come through the suction scoop, and you can use them. But here we are going back and forth and trying to retrieve all these aspects of debris and dust following the fragmentation. And really, sometimes it works very well. Sometimes it may not work so well. You might have to adjust the sheet to where the debris and dust are. Here, it is working well. Occasionally, if there's a clot or if there's a bigger bit, you might have to use a basket to just take it out. Otherwise, you have to increase the suction quite a bit, which may be not that safe, but we don't understand it so well. So here we are trying to remove all the debris and bits. And at the end, we are left with just very fine dust. Here you can see this is probably one of the last bits. It's almost like a mucoid sort of material, but the rest of the kidney was all fine. So I think pushing the limits, perhaps, is it the right thing? We don't know. I think we need more data, but here you are, pediatric patients planned for a PCNL. We have done ureteroscopy and laser fragmentation. So what do we get when we aspirate through the term condylovenae as this system or direct in-scope suction? You get this kind of fine dust, not fragment, but fine dust, which is probably enough for some cases. So what are the pros of the disc system or the scope suction? I think the channel can be used with suction. You can access difficult anatomy, lower pool, pelvical system, and you can get dust for analysis. But the fine dust is only dust less than 250 micron. You can't usually aspirate bigger bits unless the channel size increases. And it might slightly increase OR time, although I have found that actually the OR time, if anything, probably goes down when you're using suction. So and this data was looked at for 2 centimeter stone in the lower pool, no pre-stenting, no sheet, no major complications, and perhaps 10% when we defined it as residual fragment of 2 millimeter. 10% residual fragment. Bearing in mind, it is quite an accepted definition. So maybe in some studies, you would report it as completely stone-free. Now, moving forward, you have other ways of doing the scope suction. You can aspirate it, and there are different ways of doing it. And in fact, in a multi-center study that has just been completed, 95% were truly stone-free in 24 hours on CT, and there is 0 cases of sepsis. So that is incredible. And again, looking at different uses of single-use ureteroscopes, I think the most important aspect of single-use now is the smaller suction scope. I think that's really a game changer. And I think that will be probably, in a lot of ways, once the cost keeps coming down, a game changer in the field of endourology. A combination of the sheath or scope suction, or both, depending on how you use it. There are lots of different papers. I won't go into details, and there's lots more in the last year and a half. But does suction really improve outcomes? And it does. So it gives you a higher stone-free rate, as we've seen, lower infectious complications, as we've seen, and shorter operative time. And overall, therefore, improving surgical efficiency. This is another paper looking at 31 patients, and you can see in the video how you can use a suction sheath to your best advantage, because you can go exactly where the stone is, use a suction sheath, break it, and literally suck it out. And again, in this, there is no infections and no additional interventions. And perhaps you can also decrease your stenting rates, because you know there is no big fragment of dust to pass, and your basket usage, because again, if suction does the job, why do you need to open a basket? So in time, we will know whether it decreases post-op stenting rate and the basket use as well. And there are different ways of using suction, either via sheath, via scope, or via special catheters. And I don't think there is a right or wrong way. It is whatever way it fits in with your experience and expertise. So the question is it a game changer? Suction, I think, perhaps you can aim for 0 fragments with this. Previously, you may not have aimed for 0 fragments. Perhaps no intervention or re-intervention because you have done a good job first time round. The complications can be minimized, especially infectious complications. Procedure time can be shortened. And hence, because you're also improving the recurrence rate or decreasing the recurrence rate, perhaps you would indirectly also improve the quality of life. And because the kidney is not distended for that length of time, you're using suction. Perhaps the immediate post-op pain will also be less, so you can do more day case surgeries. Perhaps. I think we'll have to wait to see if data supports that. So overall, I think it's cost effective because of these reasons and also replicable because lots of centers are now using it routinely. So I think there are lots of advantages in using it and there are lots of advances in ureteroscopy. And I can't think of anything which is much more pertinent than suction. Thank you so much for listening. So I think we've got one question here. Thank you again, all the panelists. I'll bring you back to the drawing board. So for a hypothetical discussion, would anyone on the panel accept a large scope size in return for a large working channel? That's a great question. Who should I start with? I can start Steffi because you've covered pressure, temperature. For the large scope, do you think you would accept a larger working channel in a large scope if it was a compromise?
Well, that if the working channel is larger, then I might accept it. But I would like to feedback on why not a smaller scope and with a suction access sheath. That would also do the job for a larger working channel as a suction channel. So
Okay.
we do not know which is better yet, actually, because I also think that sheathless may be the way to go. So maybe all in one.
Okay. And that's the next question, actually, Esteban, for you. Do you foresee that access sheet will ever disappear or being replaced with larger scopes with larger working channel? What do you think? Do you think the sheet is going to disappear if we could do that?
Well, it's very interesting to see the trends because just a few years ago we were thinking that was the trend. Everybody was stopping using access sheets, and now that we have this new aspiration access sheet or this pressure measurement systems, as Steffi commented, we know that these access sheets really decrease intrarenal pressure and may help to decrease infectious complications. So I don't think they will disappear. Eventually, the technology, as mentioned before, we'll see what is best in regard of where the suction should be in which device. But for now, we know that they decrease intrarenal pressure for sure. We can use the smallest access sheet when using smallest scope, so reducing complications, as Lorraine mentioned. That is important. And the other thing is that I think nowadays we need to adapt to our patient. If you have a struvite stone that you need really low internal pressures, you want to take everything out, maybe you can use an access sheet to increase that possibility. If you don't have a struvite stone, you have a calcium oxalate monohydrated stone, unique stone, a patient that had never had any other stone, low recurrence rate, maybe you can switch to sheetless and small scopes, for example. I think we need to adapt. We have a lot of material, and we need to adapt our patients.
So there's no one set
to the patients.
So there's no one set formula, but you need to use whatever technology is best suited for that patient or that stone.
Absolutely.
Okay. Lorraine, Steffi has answered it, but I want to ask you, now that we've got smarter scopes, pressure, monitoring, maybe suction, does the laser energy matter anymore? So in other words, can we go a bit more bold with the laser energy? Or do you think we still are not there yet because we still don't have enough to safely measure everything we need to? You're on mute, Lauren, sorry.
It depends on what you mean by laser energy, because we may have very powerful lasers, but we as human beings, we did not change. We can't manipulate and we can't safely use very high frequencies. So probably we could be a bit bolder and use more joules, so energy, in the kidney, while we still keep our, the frequency within reasonable limits. And reasonable, it's, I would say, still something around 20 hertz. And definitely we need to adapt everything now. So this is why endourology is so amazing, and it's so important and interesting to follow all these developments, because now you need to consider the laser. You need to know the laser characteristics and what do you want to get. Do you want to get larger fragments, smaller fragments? And you know that some lasers may be able to provide more dust and help with that. And that is in conjunction with what type of scope do you use, what type of sheath do you use. So probably for the next, close future, foreseeable future, there will be two, what I think is, there will be two main directions in terms of scopes and sheaths and lasers as well. We will probably have the suction sheaths that they will be get better and better, and then with a smaller scope you will be able to use a smaller access sheath but still get enough space in between the scope and the sheath. And obviously they will be steerable, so there will be flexible sheath to allow you to get with less damage up into the kidneys. On the other hand, going back to the initial question, which is a very legitimate question, and it's a quite important one, yes, I think we will have larger scopes that will provide what we actually need, inflow and outflow, because these are the two ways. You need to get something in and to get something out in the same time to be able to control and to see and to. So this new devices, scopes or whatever however you will name them, they will probably allow us to have a continuous flow, and they will allow us to aspirate while we still have an irrigant inflow. And it's exciting. It's so interesting to see how these devices are. And obviously they will be initially a bit larger, and they will be probably in the area of 9.5 or 10 French or something like that, which is acceptable considering that it means that we won't have to use an access sheath. Adapt all these things to the patient's characteristics, and that includes another very important piece in the formula, because the architecture of the kidney, of the ureter, the type of stone, you may want to use one of the devices that incorporates everything in one go with a calcium oxalate stone, but with a struvite stone, you may want to use a larger sheath and make sure that everything is taken out and larger fragments are aspirated through the sheath. So very exciting, looking forward to the future. I think we are living very interesting times in terms of endourology and stone treatment.
Great. And I think there's another question on a similar thing. So I'll tell you my take on it. I personally think small scopes are going to stay, because exactly the reason you said, Lorian, the primary access is very important. And sometimes when they're not stented, you don't want to not have small scopes. So small scopes will stay for me. And hence the small scope in suction will also stay, because even though they may not remove fragments, they will remove the dust particles, allow you to go on without worrying about temperature and pressure. So that's one segment. The other segment where you do want to use a bigger scope with a bigger channel, I think that will also come. And you can judge, right? I mean, is the ureter capable enough to take a bigger scope? And then you need to decide whether you have a sheath with suction or whether you have a scope with suction. And I personally, and maybe it's the bias because we don't have that scope yet, my only worry of scope with suction would be, what if the channel blocks? Are you going to know that the channel is blocked and artificially? Because with a sheath, because you have two devices with a scope, you know that the sheath is blocked, right? So when you're coming on, you can see that the sheath is blocked. So unless we have a way of knowing or making it safer to know that the scope is blocked, my worry would be you're lasering or you're aspirating, then the channel gets blocked and you have to unblock it, and you might have more pressure because the channel is not blocked and suction is not working. So I do think the access sheets with suction are not going to die down, even if they have bigger channel. But definitely for some cases, a bigger channel in the scope would allow you to suck out, because sometimes it's only small fragments which the scope, maybe up to 1 millimeter, you will be able to. But with a sheet, you probably will be able to get even bigger fragments because a 10-French sheet without and a scope, the sheet will be, you'll be able to get bigger fragments. And I think it depends, but we have a lot of changes, right? You have lasers which are becoming powerful and getting finer dust. Now, if you have a TFL laser with fine dust that Esteban showed, maybe the suction scope standard or slightly bigger channel will do the job and you don't need a sheet at all. And that means you don't have to open the sheet because you save some money. The sheet doesn't have to go all the way because potentially it can be traumatic. And the sheet, so I think I agree. It is interesting times, but we're all eagerly waiting for Pusen to bring, whenever it comes out, the bigger channel with whatever size it is for us to use and really see and test it. Any last words from you, Steffi? And I'll go around the board. Steffi, any last words from you about all the parameters? What do you think is the most important in your mind? Because I know you do a lot of bench studies as well. So any glimpse into the future from the work you're doing or you've just done?
I think that there are on hand a lot of different scopes as well as the flexible with suction access sheath, the fans, but the quality varies a lot. We can see whether it reaches the lower pole, it varies from brand to brand, material to material. So there's a lot of work to work on the best combination. And I do think that we have a lot of the current studies are focused on the conventional access sheaths. So I think we have to redo everything in our new era of endourology. So
we need to define the best practice based on the modern technology, not historic technology, let's say.
We have to redo everything.
Good. Thank you, Steffi. And we'll be looking forward to your work for that. Esteban, any last words?
No, I think we have said everything. So this is actually what the title says. This is the future and present of endourology. Very exciting times.
Thank you, Esteban. Lorian, anything from you to add?
I think more or less everything has been said. We will have tools that incorporate all the features we discussed today. Probably in 5 years' time, it will be standard that we will definitely still have thinner scopes or thin scopes. They will have suction incorporated in the scope. Whether you use it or not, it's your decision. You will have sensors incorporated in the scope and you will probably use them. And we are looking forward to robots in ureteroscopy as well. So as I said, there's a lot of there are a lot of reasons to love endourology and to look forward to it.
Thank you, Lorian. And I think, in my mind, there's quad factor. So you have got pressure, you've got temperature, you've got irrigation, and you've got suction. And if we can make this quad factor, or maybe even pentafactor, and then how it influences the patients, that will be the ideal. And if we can do that and do it in a safe way of, how we incorporate all the technology, that will be a winner. Thank you again, Esteban, Lorian, and Steffi for wonderful talks and the discussion. I will hand you over to Cassia. Thank you, Cassia and Team Pusen for this wonderful webinar. Any last words, Cassia, and then we can come to a close.
Yes, so I would like to thank you again to you, Professor Somani, and to all faculty members, all the speakers from today for your inspiring presentation on most recent topics in endourology and for your great Q&A session in the end. I hope today's discussion was not only to share the knowledge, but also inspire new ideas and approaches in a pursuit for excellence in patient care. And thank you all participants for joining us today on this webinar.
And in both platforms here as well as in the Chinese platform. And thank you once again, everyone. Have a good day.
Thank you once again. Bye-bye.
Bye.